perform the anterior lockment test. It says here, the patient should have their knee flexed 20 to 30 degrees. I'm going to apply anterior. I'm going to move the lower leg in the anterior direction for any instability.
Okay, so he did a good job comparing both sides. With the anterior lockment test, anterior drawer test, pivot shift test, any ligamentous test, you have to assess both sides. Why is that? Yes, so it could be that norm. You have to look at both sides when assessing any type of ligamentous structure. Okay, so that was the anterior lockment test. If you see anterior drawer test and anterior lockment test in the same answer choices, which one would you choose? If it asks you which is the best special test to use to assess the ACL, and you have anterior lockment test and anterior drawer test within the same answer choice, which of the two would you choose?
Anterior lockment.
Anterior lockment, why?
Because with the drawer test is more flexed, and the lockment has more give, so you can really see the interior of the ACL.
Okay, so that's a good answer choice. But in addition to that, the lockment has better specificity and sensitivity than your anterior drawer test, and also it takes the hamstring muscles out of play as well. So with the knee being in a more flexed position, the hamstrings are in a more shortened position, and so that can play a role in restricting the tibia translation anteriorly. Okay, so good job with that one. Next one.
Alright. This one I'll have the hip slightly flexed, and then I'm gonna rotate the tibia internally, apply a slight valgus force, and then flex the knee.
So positive finding is a palpable clump or shift of about 20 to 30 degrees of flexion, which is indicative of anterior lateral rotary instability secondary to tearing of the ACL and posterior lateral capsule. Okay, so note that the pivot shift test is going to assess the integrity of the ACL and the posterior lateral capsule. All right.
Valgus stress test.
Describe what you're doing, man.
Yeah, describe what you're doing.
So I'm holding right here at the ankle, and then I'm doing a valgus movement. And I'm looking for any kind of translations towards the medial way. And then after I do that, you'll redo it in 20 degrees flexion.
Which one is more specific?
The 20 degrees flexion is for MCL, and then the extension is MCL, PCL, and posterior medial capsule.
Okay, so if you really want to target the MCL,
Yeah.
and be more specific, you go to 20 degrees knee flexion. Okay?
Yes, sir.
All right, go ahead and do the varus stress test.
Okay. Same thing, so doing the varus movement. And then same thing with the specific, if you'll do it, you want it in 20 degrees flexion to just target the LCL.
Okay, what are you looking for a positive test?
No endpoint and or excessive translation, either medially or
Okay, how you gonna determine that?
Testing both sides.
Good job. Testing both sides. What we're looking for when she contracts her quadricep muscle, we're looking to see if the tibia translates or moves posteriorly.
Okay. For the posterior sag test, it's a test to determine PCL injury. I want to have my patient supine, flex her hip to 45 degrees and her knee to 90 degrees. Okay, I'm going to ask her to contract her quads, to keep your foot on the plinth. Good. And I'm looking for a posterior translation of the tibia relative to the femur. And if there was excessive translation of the tibia posteriorly on the femur.
After she contracts the muscle,
Yes.
now she's in a resting state. She
Okay.
goes back into the resting state.
Okay.
So now in the resting state, when the quadriceps are inactive, when they're not activated, what does her tibia look like in reference to her femur?
Okay.
Okay, so does the tibia displaces posteriorly, or is it still in its anatomical position that it was normally in?
Okay. So you relax, Liz. Okay. Since she's relaxed and she does not have any posterior translation of the tibia, it is negative for PCL injury.
There you go.
Okay.
So it's like it's like you have phases of this test.
Yeah. Okay, so contract, relax, and then observe.
There you go.
Okay.
So do the same thing on
All
contralateral extremity.
right. Okay, so if you'll flex your hip to 45, knee to 90. Okay. Can
Okay,
you?
so you're gonna notate what a tibia is relative to the femur at this point.
Okay. If you'll contract your quad for me. Good. It says on the ground, relax. Are you relaxed? Okay. Alrighty, it's the same position it was in before we contracted. So she has no PCL injury.
Okay, good.
All right.
There you go.
Okay.
All right. So we want to
Walkman test. It's a test to determine PCL pathology. I'm going to have my patient supine, and I'm going to flex her knee to about 20 to 30 degrees. I'm going to have my proximal hand on her lateral distal thigh, and my distal hand on her medial leg, right below the tibial tubercle. And then I'm going to apply a posterior, stabilize the femur, a posterior translation of a tibia on the femur. She has no, well, a positive sign would be excessive posterior translation, which she did, of the tibia on the femur, which she did not have. So she's negative for PCL pathology. And I can do the other side. So,
And so be aware on your practical exam not to voice your impression until after you assess both.
I flex the test knee to 20 to 30 degrees of deflection. Going to have my proximal hand on her lateral distal thigh, and then my distal hand on her medial side of her leg, right below the tibial tuberosity. I'm going to stabilize her femur and apply a posterior force. And there is no. Well, after I have assessed both of the knees, I can confirm that she has no PCL injury because they are both the same.
All right.
All right.
I'm going to assess the medial meniscus. I'm going to use my distal hand to take the tibia into external rotation. Go ahead and put it in a flex position. So I got the knee flexed. My distal hand has her tibia in external rotation. I'm going to apply a valgus force as I extend her while maintaining external rotation. Okay, so I'm going to keep that at valgus force there. Then I'm going to repeat. Okay. All right. So I'm listening for a popping or a feeling for some type of clunking sensation. That was assessing the medial meniscus. So now to assess the lateral meniscus, I'm gonna internally rotate her, keep her flexed, internally rotate her. And now I'm gonna apply a varus force as I extend her. So I didn't hear any popping, clicking, or clunking. Then I'm gonna go assess the other side. So.
This the end of her leg. We're gonna put her in full flexion. And as we come down, we're gonna push a valgus force coming down. And this is for any popping.
Make sure you maintain external rotation of the tibia.
And that's with my distal
challenging
hand.
part.
The distal hand, right?
Your distal hand is maintaining the tibia and external rotation.
We're gonna go back up. Can I go underneath or go on top when I do that other way?
It's easier for me to come over top. So doing your practical, you have to make it very clear, or else I'm just gonna be, I'm more prone to deduct points than add points, right? So, if I don't see this clearly externally rotated like this, you can get it right here, you can do this. If I don't see this done clearly, then I'm gonna be more inclined to deduct points. So I know the tibia, I wanna assess the medial, and I'm gonna even use my distal elbow to help maintain that. So you see how I'm using my distal elbow to maintain the tibia in external rotation? Then I'm applying my valgus force as I take her into extension. This is obvious that I have her externally rotated, and I'm applying my valgus force to assess the medial meniscus. You're gonna have to do this on a practical. So now, you may end up getting this. You may end up getting this on the practical. This may end up being a number you pull. Then I'm gonna come right here. It's obvious that I have her in internal rotation. I wanna assess the lateral meniscus. So look how easy I made this on myself. I got my distal hand maintaining internal rotation, and I just put my hand right here. I didn't move much, right? And now I apply my varus force as I take her into knee extension. So the varus force with internal rotation, assessing the lateral meniscus. So then you just gotta figure out what you're gonna do with your body. But I do wanna see the obvious internal, external rotation with the appropriate force when taking the person into extension. So you have to practice that. If you end up struggling with it, the content the things that you end up struggling with, you gotta go back and get classmates to check you off. Get more than 5 classmates to check you off if you struggle with it. Because if you struggle with it, what does that likely mean? That likely you're gonna get it on practical. Because you're gonna say, I don't want it, and the law of attraction is gonna give it to you. Because the law of attraction doesn't negate don't. It just look at want. You're gonna end up getting it based on the law of attraction.
At least.
And so I would flex this left knee to 90 degrees. And I would have my hand resting on their hamstrings. And I would have my, I would stabilize on the distal thigh. And then the distal hand would be on my subject's heel. It says, with the distal hand, medially and laterally rotate the tibia while applying a downward force through the heel. So we have to lower it so I can get a good line of force.
There you go.
Medially and laterally rotating. And see if there's any pain. Are you in any pain or anything? Okay, so if there's any pain or I don't feel any clicking or any restriction, so it's negative. if there was pain and clicking.
So if you miss both sides, and I say, man, I've stressed this the whole semester, I'm gonna have a tendency to dock way more points because I've been stressing it. I've been stressing it the entire semester, right? So I'm like, man, it should be a no-brainer by now.
I did feel a little bit of clicking in this one, but this is the one she had broke.
Oh. She broke that one. What did she break?
She broke her ankle, right? Is your ankle? Yeah.
So y'all see that? So now, what am I doing to assess her posterior tibialis muscle extensibility? So we know what does it do. So we know what the rear footed does. What? It's an inverter, right? So I'm gonna evert her. It's also a plantar flexor, right? So now to assess the extensibility of it, I'm gonna come right here and dorsiflex. So you see how much range of motion she gets. Notate that. Notate that. Y'all notated that? All right, now let's come over here. Ooh wee! That right there. That right there. That's it right there. Yeah, that's a big difference. Because that's it. What do you feel? So, pay attention again. See that? See how much dorsiflex you get? See how much extensibility that posterior tibialis muscle has compared to this one? That's it. As far as I can go. And so, that's a problem. That's posterior tibialis muscle tightness. Okay? So, so whatever happened, that muscle is in a shortened, tight position, probably weak too. You probably need to.
Is it Vesely? The Vesely test. So we have the subject standing on one leg, with the knee slightly flexed, and the examiner holds both the subject's hands to provide support and balance. Now I'm going to have the subject twist back and forth 3 times, rotating the knees and body internally and externally. Now, a positive finding would be if there was any medial or lateral joint line pain, or sensation of catching or locking, suggests a positive test and an injury to a meniscus. So when you internally rotate, that would be for the lateral meniscus, and if you externally rotate, that would be for the medial meniscus. I would now assess the other side. So he's getting repeated at 20 degrees of flexion.
Go ahead and repeat it at 20 degrees. With your evidence, when you increase it to 20 degrees of flexion, that is going to improve the sensitivity and also the specificity according to Caracadios. Okay. And the other 2 studies, they only did it at 20 degrees of flexion. But according to Caracadios, is going to improve the sensitivity and specificity if you increase it to 20 degrees of deflection. All right. Now you two are going to do the noble test and over test. Over is on page 354. Noble test is on 293.
Doing the noble test. So we have the subject laying in supine. We're going to flex the knee. We're going to flex the knee to 90 degrees. And I'm going to stand on the involved side, place my thumb over the lateral epicondyle of the involved knee, and the other hand is placed on the subject's ankle. So then I'm going to passively flex and extend the subject's knee while maintaining pressure over the lateral epicondyle. Now, if there is any pain present under my thumb while the knee is positioned in 30 degrees of flexion, that's indicative of iliotibial band friction syndrome. So I'm going to flex the knee to 90 degrees. I have my thumb on the lateral epicondyle and the other hand placed on my ankle. So I'm going to passively flex and extend while my thumb's in the lateral epicondyle. I'm going to make sure, if there's any pain under the subject's knee while it's in about 30 degrees of flexion, that means that iliotibial band friction syndrome is indicated. Any pain there, sir?
No, sir. Okay. So, let me come right here, just to finesse it. So I got my thumb right here like so, right? Don't be afraid. All right here, I'm gonna come right here like so. And I'm palpating right here up on the lateral aspect of the femoral condyle. I'm kind of strumming as I do that. So I take them to, ooh, I feel it right there. So I'm flexing and extending as I have my thumb right here. So I don't have to do this and then I don't have to do that like that. So I don't have to flex and extend him at the hip as well. I can keep his hip fixed while doing all the movement at the knee joint. So you see, I'm not moving his hip. See, I'm just moving the knee joint. You see that? While keeping this pressure right here. Did you feel that difference between how I did it and how Emery did it? And so you may have to, it just depends. You may have to come underneath and put your thumb right here like so. It just depends on the person and how you best achieve that. This will help keep his leg fixed like this. Then when you reduce the movement at the hip.
We're going to perform the over test. So you have your patient in the sideline position. I'm going to make sure I stabilize at the hip here. I'm going to passively abduct and extend this hip. Now I'm going to slowly lower to the table. To assess the other side. So you passively abduct and extend the hip. that means that this is a negative test. A positive test would have had his hip stuck in ABW.
Okay, great. Scoot to the edge of the table. Thank you, Aaron. So I kind of like to bias the patient towards the edge of the table, come back a little bit more. There we go. All right, just like so. All right, lower your leg. I kind of bias him and I'll block him, prevent him from falling. But I want to see if his leg can make it to the table. Or sometimes I want to see if they can go past the table. So that's why I kind of bring him to the edge. But if he can make it to the table, then it's considered negative. So, or I will bias them towards the edge just to see if they can make it to the level of the table as well. You can do it either way, but textbook it does say if the leg can make it to the table, then it's negative. Okay. The important part with this, in order not to get a false negative, okay? Okay, so according to Coney, keeping it straight puts more tension. So I stand corrected. We want to keep it straight then, and lower it. Like so. Okay.
Also notice how Dr. Carter's keep your hip extended. I saw a lot of you that hip was drifted back into flexion, so make sure you keep that hip extended.
So good. Keep it straight. When in doubt, go with the textbook. All right. That's why I always say fact check. Good job. Is there anything else? I think that's it. All right. Patellofemoral dysfunction. So the hallmark test for patellofemoral dysfunction is your Clark sign patellar grind test. So we're going to do the patellofemoral dysfunction Clark sign patellar grind test along with the neurological assessments. Those should be performed in neuro as well. So let's go with 2 new volunteers. So you're going to do patellofemoral dysfunction and the neurological assessment.
All right, so we're going to start with a Clark sign. So on this one, the patient's going to be lying spine. Straighten the leg out for me. So you're going to ask the patient to contract the quadricep muscle while the examiner applies a downward and inferior pressure on the patella. So go ahead and contract your quad muscle. So positive finding is pain with the movement of the patella or an inability to complete the test. It's indicative of chondromalacia patella.
There you go.
Very good. So that's Clark's sign. The patellar apprehension test. All right, now contract. Anything? You all right? All right, contract. You all right? All right. So we'll do the apprehension test. All right, just relax right here. You hang with it?
Prone knee bend is assessing the femoral nerve, and it could capture branches of the femoral nerve, like the lateral cutaneous nerve. Y'all ever heard of that nerve? So the lateral cutaneous nerve is sensation only. So likely, if this test is positive and this person has lateral cutaneous nerve involvement, this person may likely report abnormal sensation along that anterior lateral aspect of the thigh. So that will be a positive prone knee bend if they do. But you perform it in a similar manner as you would perform an Eli's test. Prone knee bend. All right, we got somebody. Some clinicians prefer to using the femoral slump test in place of the prone knee bend to remove the effect of gravity. Okay, the prone knee bend test theoretically stretches the femoral nerve using hip extension and knee flexion to stretch the nerve termination in the quadricep muscle. However, as with most neurodynamic mobility tests, other structures follow the same route. For example, both the rectus femoris and the femoral nerve travel anteriorly to the hip and the knee. Therefore, both the femoral nerve and the rectus femoris are stretched with a combination of knee flexion and hip extension. All right. The lateral cutaneous nerve of the thigh and the hip flexors travel anteriorly to the thigh and may also be stretched with the hip extension component. All right. So we talked about the lateral cutaneous nerve likely being involved and can be identified with this test. All right, the prone knee bend test is performed as follows. We did that. The manner is likely to produce a stretching sensation on the anterior aspect of the patient's thigh. Alright, the zone at which the dura is stretched is 80 to 100 degrees of knee flexion. So this is what Dr. McClure is talking about. Knee flexion greater than 100 degrees introduces a rectus femoris stretch and lumbar spine motion into the finest. Several sensitizing maneuvers can be used, including hip extension, plantar flexion, dorsiflexion, or head movements. The test is positive if there's a reproduction of unilateral pain in the lumbar area, buttock, posterior thigh, or a combination of 80 to 100 degree range of knee flexion, which could indicate L2, L3, or L4 nerve root impairment once other conditions have been ruled out. So that's what I was talking about with indicating lumbar nerve root involvement. So that's if that person has symptoms reproduced between 80 to 100 degrees of knee flexion. Let's see, anything else? Perhaps not surprisingly, the reliability and validity of the prone knee bend are not yet known, but it just gives you information. Okay. All right. So the zone at which the dura is stretched is 80 to 100 degrees of knee flexion. I'm trying to.
This is the prone knee bend test right here. In pain? Okay. Any pain on that side? All right, you can roll over in the back. Go into this next one. So this is the 90-90 straight leg raise test. So the patient will be supine.
Hold on.
Okay.
You want to pick up right where you are. Sit up for me. Go ahead, sit up for me. Roll your pants leg up. Roll your other pants leg up. Little bit, very diminished. Right there. Why am I doing this? What do you think about that? Okay. What did you think? So based on the prone knee bend test, oh, there we go. There we go, that's better. I had a better angle. How did I do this? There you go. So his test was negative, so I expected his DTRs to be somewhat normal because it was negative. But the reason why I did this because you need to know what else can you go to rule in and rule out. So like Dr. McClure said one day, what can you do next? Well, DTRs is something you can do. You know, if you're expecting nerve root involvement of a particular segment. So now you have to know the patellar tendon tap test. I can rule in and rule out L4, right? L4 nerve root involvement. You see? So that's why I say it's information. It gives you information and can take you to somewhere else to confirm and rule in and rule out. Okay, good. So sometimes you may have to keep trying it. All right, go ahead, pick up where you left off.
Alrighty. So this is going to be the 90-90 straight leg raise test. The patient will be lying on their back. Then I'll have you bend up both your knees at the same time for me. You can hold behind your leg. And then they're just going to extend one leg at a time. So extend straight up towards the ceiling. Good. Do the other side. Good. So right here you're looking to see if the knee is flexed greater than 20 degrees whenever they extend. Then the hamstrings are considered tight. Looks like you got tight hamstrings on both sides. So yeah, this is 90-90 straight leg raise test.
Yeah, this is 176.
Yes, sir.
Okay. So I want to do.
All right, so this is a unilateral straight leg raise test. So the patient is supine with both hips and knees extended. So you have the patient completely relaxed, and you slowly raise the test leg. Until there's tightness. You're right. And then you dorsiflex the ankle. And then you instruct the patient to flex their neck. So bend your neck up. Good. Any pain in your low back? Okay. Yeah, so positive finding is leg and or low back pain occurring with dorsiflexion or neck flexion.
I think you do neck flexion when you longer.
Okay. All right. Flex your neck. Right on the side. Flex your neck. All right. Any pain in your low back with that? Yep. So, positive finding for this is sciatic type pain. Forward while the examiner holds the head and chin upright. So, the leg and put the patient in a dorsiflexion as they lean forward. Any pain? All right, relax. The other side. Sit leg, dorsiflex. Any pain? Good. All right. So, with pain, is it kind of like down your back? Back of the leg? Okay, that could just be hamstring tightness. All right.
And you always want to ask the patient also. Now this is very, very important. Don't ever forget this. When you're assessing pain, you want to ask your patient to describe the pain. All right, you don't just want your patients to rate the pain, which is what you will see in the clinic a lot. But you want the patient to describe the pain and talk about the nature of the pain. Why is that so important? Yes, it's going to give you some idea, allow you to generate some type of hypothesis as to what structures can be involved. Okay, so specifically in this case, you want your patient to describe it. If it is positive and they have a reproduction of symptoms, more than likely those reproduction of symptoms are going to be neurological symptoms like sharp, shooting, burning, radicular type of pain, numbness and tingling. Those are the type of things you may hear. Okay. All right. Place your hands over your chest, arms over your chest. Okay. I have a timer test your functional strength and endurance. All right. This is a chair rise test, or 30-second chair stand test. This is to see how many times you stand in 30 seconds. So this is a functional test that you can utilize with anybody who comes in with any type of lower extremity condition across the board. It doesn't matter what the lower extremity condition is. This is a go-to functional test that you can use to assess lower extremity muscular strength and endurance. So when I say go, I want you to start standing up and sitting down as many times as you can. I'm gonna stop the timer at 30 seconds. Set, go.
Y'all so quiet.
All right, that's it. So I counted 19 reps. So based on her age, as a grader, so she performed greater than 12. Okay, so for her age, so the age starts at 60 to 65, but anyway, anyone younger than 60 applies to that age range with this test. So this is one I utilize quite a bit in the clinic. This is a component motion at the patellofemoral joint required for knee flexion. Again, the knee is going to be extended, full extension, or slightly hyperextended. I come with the web space around the superior pole of the patella, and now I glide the patella. Now, this is interesting. There's some clumping with the inferior that I did not feel with the superior. That's fascinating. You just go off what you feel. You don't make anything up. Do you sense that?
Yeah.
Okay. Now, did you sense that with the superior? So the same here. So I get confirmation from my patient. So, oh yeah, as soon as I go into it, there's a clump. Every time, just about every time. Yep. So I'm gonna notate that. So I would notate that that would go into my quality. Okay. So I would describe that as smooth. I would describe that as a clunking sensation, noted with the inferior glide of the patella. So that doesn't get a smooth. All right. So we notate that because that could be a bony anomaly, something arthritic, and that may lead me to doing what special tests at the knee that we practiced yesterday. Yeah, that may lead me to doing a Clark. All right, I'm gonna come over here since the inferior glide. Oh, same thing over here. Did you feel that, Sam? So it's the same thing over here with the inferior glide. So the quality, I still got a clunking sensation, some crepiness, more crepiness on this side. More crepiness on this side. Like a little grating, crunchy sensation. That's what I'm feeling with the inferior glide. So you want to notate that when you're working with your patients, because there could be something going on. I don't know. All right. Contract your quad, brother. Any pain with that? Okay. So no pain with that. All right. Infield for both. I would say a normal, firm infield due to tensioning of the distal rectus femoris / tendon of the rectus femoris as well. And the grade I would consider normal, grade 3, when comparing both of those with mobility wise. I didn't notice any restrictions, but with the quality, I would say crepitus, clunking, more crepitus on this side. So if you work with self, let me know if you feel the same thing for interrater reliability. All right, that's the inferior glide of patella. Now, I'm gonna assess the lateral glide. So the lateral glide and medial glides are joint play motions. So there are joint play motions required for every movement at the knee. All right. So I'm gonna come on the opposite side and get on the medial aspect of the patella and just glide it laterally to see if he is apprehensive of anything and compare the glide to the other side. So that's the lateral on that side. Then I'm coming around to the opposite side, like so, to assess the lateral. Okay, so his lateral glides are smooth. There's nothing restricting his lateral glides. There's no avariant motion. So good quality lateral glides. The infields were normal firm infields due to likely the medial retinaculum tensioning and tightening. So normal firm infields, and grades I would say 3. They were symmetrical, grades 3 on each side. Now I'm gonna assess the medial glide. So medial glide, and be on the opposite side of the same knee. Now, guess what? The medial glide quality on this side, crunchy, crepitus, like some little clunky, is different from the lateral glide. Did you notice that? So y'all gotta pay attention to this. Whoop. There it is, right there, each time. It's something going on right there. I don't know what that is, but it's like a little clunking sensation. It's not smooth, I can tell you that. But it's just giving me information. I'm getting information that the same thing over here. It's something right there, right there. What is that, Seth?
One of my ligaments popping over.
Okay, that could be what it is. I don't know. See, that's why I ask my patients sometimes, what do you think it is? So he thinks it could be one of his ligaments popping over. But even if that's so, it's not smooth. There's some type of clunking sensation that I'm feeling when I do that. So I would not grade that as smooth. So when you're assessing your patient, don't just be saying, making up something, going through the motion. Say what you actually feel, okay? All right, and that's how we move forward as therapists. Okay, the amount of motion was the same, so that's probably his normal. So basically, with that being his normal, for him, I'm likely gonna grade him as normal, grade 3. I'm not gonna try to be rocket science and make up stuff, all right? And for his infield, it's likely gonna be a normal firm infield due to the lateral retinaculum and lateral soft tissue structures. So that's the lateral glide and the medial glide of the patella. Those are joint play motions. The superior glide and inferior glide of the patella, those are component motion, all right? So make sure you notate that. Make sure that during your lab practical, if you tasked with assessing anything at the patella femoral, make sure that your patient is in a loose pack position of full extension. And to be on the safe side, you may want to prop something under the distal leg. So that's 4 techniques: superior glide, inferior glide, medial glide, and lateral glide that you are assessing. Because remember, we're in the course for assessment now. Eventually, we're going to do the same thing for treatment. So go ahead. This one, I'm actually going to put his knee in a loose pack position. I'm going to place my wedge under the knee with a pillowcase or towel on top. There we go. Good. I don't want the wedge to cross the joint line, but I want it right down the very distal aspect of the femur, okay? And not blocking the joint line, so that's good placement. So now that puts his knee in about 15, 20 degrees of knee flexion, somewhere in that ballpark. Now I'm gonna raise him so that I can use my body. So I'm gonna stabilize, and I got the wedge stabilizer, and I'm using my body leaning to do the distraction. So this distraction of the tibia on the femur. Again, distraction being a joint play motion. All right. Good. Good. And so notice in the picture how the direction that I have the wedge in. So that's the direction you want the wedge, that's how you want the wedge placed. All right. Again, stabilizing and using my body to lean to create that distraction. So a weight shift onto my left leg. So I'm just weight shifting. All right. So his distractions were normal. I would grade those as normal. Smooth, normal, firm infields. Okay. Due to tensioning on his MCL, LCL, likely ACL, PCL, so tensioning of those ligaments. But those are, that's a normal firm infield. So that's distraction of the tibial femoral joint with the knee in the loose pack position. Again, joint play motions necessary for knee flexion and extension, and also tibial internal and external rotation. All right. Now, what you all have to pay attention to on your practical exam is what kind of accessory motion you're going to be asked to perform. So it may say assess a joint play motion necessary for flexion. But you know joint play motion is going to improve everything, right? So it may say assess a joint play motion at the patellofemoral joint. Assess a joint play motion at the tibiofemoral joint. So some of you all may not pay attention, and if you don't pay attention to what the prompt says, and then that if you make a wrong turn, that can be disastrous, because that one wrong turn can equate to a retake. Turn on your stomach for me, Sal. So this can also be achieved prone, with the patient prone. Again, the knee is still going to be in a loose pack position. You flex the knee, like so, stabilize, and distract. Again, I'm using my body weight to create that distraction of the tibia on the femur. Same thing, like so. Now, when would this come in handy for me? When I'm working with a patient, and say I have a patient in a position and I don't want to move them out of that position, I want to do as much as I can in that position, and I'm working with them and they're in a prone position. Say I've done some prone knee hanging, I've had them to do some hamstring curls, some hip extension exercises prone, and I've just done a lot of prone work on I'm going to transition into prone work after soft tissue and joint molds. I'm going to just leave them prone, and I'm going to do the distraction with them in a prone position. Okay, so that's when this comes in handy, if you already have a person in that position. Okay, so that's the distraction of the tibiofemoral joint in prone. So I'm going to show you that way. So we go over that one. We'll do the posterior glide and anterior glide, and let you practice those. All right. Go ahead and turn back around for yourself. All right. Again, I'm placing my wedge. Now, when you are assessing, I cropped it out this picture, tried to make it big so you can see the knee joint. But the person's heel is hanging off the edge of the plinth. So scoot to the edge of the plinth. And it's notated, it should be notated in here somewhere. But anyways, when you're assessing posterior glide, make a note, posterior glide, anterior glide of the tibia on the femur. Make sure that the heels are hanging off the edge of the plinth. The reason being, if the heels are on the plinth, then that can create some unwanted torque and torsion through the tibiofemoral joint when you're assessing the tibiofemoral articulation component motion. So make sure that the heels are floating off the edge of the plinth. All right. So now I'm gonna assess the posterior glide of the tibia. So we know based on our concave, convex rule, with concave moving on convex, the glide is gonna be in the same direction. So with flexion, the glide is going to be posterior. So when I flex, my tibia moves posteriorly. When I flex my knee, so therefore my glide is gonna be posterior because it's concave on convex. All right. So come right here like so. I have the wedge stabilizing the posterior aspect of the thigh, distal thigh, and my stabilizing hand is gonna stabilize the anterior aspect. And I'm gonna get right here, just below the joint line. So I'm just below the joint line, and I'm gonna assess his posterior glide. And now I gotta compare both sides because this could be different for everyone. And so now, I can't make no clinical impression on self. I gotta go look at it, assess his other side with this one. All right. Now, another thing too is alignment. Make sure you get them aligned, good alignment. Alignment is key. So make sure the person's not excessively externally rotated. So you see this? Make sure the person's not excessively internally rotated. So you want to get them as neutral as possible. So that's the best alignment I can likely get self in. All right. I gotta go back to the other one now. I'm feeling like I got more mobility on this side with that, but let me double check. Let me recheck my senses. When I do this, you all with patients, I'm actually feeling. So, yeah, this side is making me work harder. So now, both motions, I'm gonna compare. Both are smooth. So there's nothing, no aberrant motion. He goes right into the glide. So both are smooth. As far as grades are concerned, I will give it grade this one a grade 2, slightly hypomobile in comparison to this extremity. Okay, that would be the grade. In the infields with this one, I'm gonna go normal firm infield due to the anterior joint capsule tightening. And this one, I'm gonna go abnormal firm infield due to anterior joint capsule tightness. Now, why did I say anterior joint capsule tightness? Yeah, because it's concave on convex. And so the portion of the capsule that you're moving away from is going to be the portion of the capsule that's going to contribute to your infield. Okay. All right. So that's the posterior glide. So that's how you go through it. That's how you compare and contrast. You verbalize your quality of motion. You verbalize your grade and your infield. Don't forget that for your component motions and joint play motion. So now, that's the posterior glide. Now I'm gonna do the anterior glide, okay? So I already got him set up. He's already set up. So anterior glide, we know anterior glide is a component motion required for knee extension, okay? So the tibia orthokinematically has to glide anteriorly for knee extension, all right? So now I wanna assess that. So he's set up, I got the setup, I got him aligned. So alignment is important. So making sure the person's not in external rotation excessively or internal rotation. I have him in a loose pack position. So my wedge and my towel on top of the wedge, or either my sheets on top of the wedge, helps to create that loose pack position. Come underneath. I'm gonna work through the skin and soft tissues and impart my anterior glide. So this could be tough if you got a lot of soft tissue to work through, but you can try to get a feel. So I gotta work through the soft tissue, now impart that inferior glide. And here's an anterior glide. I said inferior glide, but here's an anterior glide of the tibia on the femur. And you always wanna verbalize what you're moving on with. So anterior glide of the tibia on the femur. Now that made me work, so now I gotta compare. I'm gonna notate in my head that made me work. Seth made me work on that one. That was his right lower extremity. Let me see what the left lower extremity feels like. I'm gonna kind of get like this so you all can see me. All right, alignment is important. I got him aligned. I got his heels floating off the edge of the plant to prevent any unwarranted or unwanted torque or torsion. All right, okay, so I'm gonna have Contorter double check me. He was symmetrical on both sides with the anterior glide. They both made me work about the same. So they both got about the same amount of motion. So they were symmetrical. That was just his normal. So that would be a grade 3 for him. The quality would be smooth, and his he would have normal firm infield bilaterally due to posterior capsule tightening. I'm about to perform or assess. I'm about to assess the posterior glide of the medial tibial plateau on the femoral condyle. So this is a component motion required for knee flexion and internal rotation of the tibia. So make sure you pay attention to this one. The setup is just like doing a posterior glide of the tibia, except I'm gonna focus on gliding only the medial tibial plateau on the femoral condyles, okay? So the medial aspect of the tibia on the medial femoral condyle to improve, or to a component motion that's necessary for knee flexion and internal rotation of the tibia. So guess what that means? You can get a prompt that says assess the component motions necessary for internal rotation of the tibia and knee flexion. So you have to look out for that. I'm warning you right now, I'm informing you right now that your prompt can say that. So if it says to perform a component motion necessary for internal rotation of the tibia and knee flexion, this is the one I'm expecting you to perform. I'm not expecting you to perform the posterior glide of both tibia plateau on the femoral condyle. I'm expecting you to perform the posterior glide of the medial on tibia plateau. So I'm come right here. Now my thenar eminence, hypothenar eminence is gonna be more biased on the proximal aspect, proximal anterior aspect of the medial portion of the tibia. So you see how I am right now? So for the posterior glide, my hand is like this and imparting the posterior glide. But for the posterior medial, for the posterior glide of the medial aspect, my hand is like so. And now I'm performing a posterior glide of the medial tibia plateau on the medial femoral condyle. Now, again, based on, okay, and I'm gonna go and do the other leg for demonstration purposes. Again, I want them in a loose pack position. Make sure you have them in a loose pack position. Make sure you all are properly placing your wedge and aligning the lower extremity. That's important. So make sure the wedge, I'm gonna remove this so that you can see the wedge and see how I have the wedge. So now you see the wedge and you push that. So the wedge is not blocking the joint line, but it's on the distal aspect of the thigh, posterior thigh, but it's not blocking the joint line. I come here like so, and now you see my hand placement, and I'm mobilizing and assessing the posterior glide of the medial tibial plateaus on the medial femoral condyle. This is a component motion required for deflection and tibial internal rotation. So now I'm gonna stay just like this. All right. Now the next one is the posterior glide of the lateral condyle of the tibia. This is required for knee extension and external rotation of the tibia. So say if someone is having a tough time with the screw home mechanism with knee extension, and maybe they're not getting that external rotation to occur within the last 20 to 30 degrees of knee extension, then this would be likely a beneficial technique that the patient could benefit from. So I'm gonna come, same concept, come like so, stabilized. And now, you see, now my thenar, hypothenar eminences are on the lateral aspect of the anterior tibia proximally. And now I impart my posterior glide to the lateral aspect. And this is to improve tibia external rotation and knee extension. Okay? All right. Got that? All right. That's that one. The anterior tilt of the tibia, which is a component motion. So, but this is a component motion that's necessary for knee flexion beyond 100 degrees of flexion. So what happens is you may have some patients who just have a tough time achieving full knee flexion range of motion. And they can get to 100 degrees, they can maybe get to 115 degrees, but they can't reach that 120 to 130. And you try to get them to that 120 to 130. This may be a beneficial technique, which is called an anterior tilt of the tibia. And so with this one right here, go ahead and bend your knee for me. There we go. This one's unique. It's different because you're trying to tilt the tibia. And it's all about the motion of your hands. And so I got Seth right here. I got him flexed. And so my hands are right here. And my motion is like this to try to tilt the tibia anteriorly. And so that's what I'm doing. Well, I gotta work through the skin, and now this is an anterior tilt. May require you to use some force, but this is what I'm doing. This is the motion of my hand, like so. See that? My motion is coming back like that in an attempt to tilt this tibia anteriorly. And so, that's a good one to utilize if you got a patient who's having a tough time with that.